Hey everyone, welcome back to The Explainer. If you've ever looked at a medical study or maybe listened to a pitch for a hot new drug and thought, these numbers feel like they're playing tricks on me, well, you are absolutely not alone. Today, we're doing a rigorous audit of clinical impact measures. We are going to separate that flashy statistical noise from the true underlying patient signals.
Let's kick things off with a hypothetical. Imagine a pharma rep is sitting right there in your office. They lean in and ask, hey, would you prescribe a new drug that cuts patient mortality by 50%? Instinctively, you're probably thinking, yeah, absolutely. I mean, it sounds like a literal miracle, right? But as we dive into the data today, you're going to see exactly why that question is actually a massive statistical trap.
Whenever I'm evaluating clinical data, I honestly like to picture a courtroom. On one side, you've got the marketing lawyer, and that lawyer is always pitching the relative risk reduction, or RRR. It's flashy, it sounds super impressive, and it's totally designed to sway the jury. But then you have the judge. The judge doesn't care about the spin. The judge demands the absolute risk reduction, the ARR, just the raw, absolute baseline facts of what actually happened to the people in the trial. Let's look at that lawyer's pitch first. So, relative risk reduction, or RRR. This tells you how much the treatment reduced the risk of a bad outcome relative to the control group. It's super common in studies, and honestly, it's exactly what you're going to see plastered across the headlines. But here's the catch. RR is basically notorious for acting as statistical noise. It consistently overstates the actual magnitude of a drug's effect. It inflates the perceived benefit, especially, and this is key, especially when the baseline risk of the disease is already super low. Okay, let's pivot to the judge's standard. Absolute risk reduction, or ARR. This is the raw, unvarnished percentage point difference in event rates between the control group and the intervention group. ARR just completely strips away the marketing spin. It gives you the absolute benefit of the therapy. That's why it's the true signal of clinical impact. It answers the one question that actually matters. How many real lives were saved out of the total population? And finding the ARR? It's literally just basic subtraction. You take the control event rate, so the percentage of folks in the placebo group who had the bad outcome, and you subtract the experimental event rate, which is the percentage in the drug group who had that same bad outcome. That's it. It shows you the exact tipping point between the baseline risk and the experimental risk. Let's circle back to that miracle 50% drug from earlier to see this in action. Imagine a disease where 2 out of 100 people die. So a 2% mortality rate in the control group. Now our shiny new drug drops that mortality down to 1 out of 100. That's a 1% experimental event rate. Now the relative drop from 2 to 1, yeah, that's a massive 50% relative risk reduction. There's the lawyer's pitch. But the absolute risk reduction, 2% minus 1%, is just a tiny 1%. The judge's demand reveals the truth. The drug only saved 1 additional person out of 100. So the absolutely crucial takeaway here is this. Relative risk reduction is statistical noise that inflates the perceived benefit. Absolute risk reduction is your true signal of clinical impact. Listen, one of the dumbest, and I mean most common, mistakes we can make is calculating clinical impact using that relative noise. You always have to derive your metrics from the absolute difference. Now, I get it. Percentages, even absolute ones, can still feel kind of abstract, right? To make absolute risk truly useful right there at the bedside, we need to cross the diagnostic dividing line. We have to move from percentages to actual human beings. We need to answer the question, how many patients do I practically have to see and treat to make a real difference? And that brings us to just a beautiful metric, the number needed to treat, or NNT. Simply put, this is the number of patients you would need to treat with the experimental therapy to prevent exactly 1 negative outcome. NNT is the ultimate efficiency metric, guys. It takes that abstract data and translates it directly into clinical effort and patient benefit. Calculating it is a breeze. The NNT is just the reciprocal of the absolute risk reduction. You literally just divide 1 by the ARR. Remember that 1% ARR we talked about? As a decimal, that's 0.01. Divide 1 by 0.01, and boom, your NNT is 100. You have to treat 100 people to save 1 life. It's that simple. Let's look at a classic board exam scenario to see this in practice. We've got a drug to treat severe itching, pruritus, in patients with a liver condition. In the placebo group, the event rate is 60%, but in the drug group, it drops down to 27%. Okay, first find the ARR. 60% minus 27% gives us an absolute risk reduction of 33%,
or 0.33. Next, find the NNT by dividing 1 by 0.33. That gives us 3. You only need to treat 3 patients to relieve itching in 1 person. Now that is a highly effective, incredibly efficient therapy.
But wait, there is a strict mathematical law you've got to follow here. You must always round up to the nearest whole number, always. So if your math spits out an NTT of, say, 7.1, your final answer is 8. Why? Because, well, you can't treat a fraction of a patient. You have to treat that entire 8th person to guarantee that one successful outcome.
But hey, efficacy is only half the story, right? Now we have to run the safety audit, because every single medical intervention has a structural cost. There's always a side effect or a complication lurking somewhere. To measure that cost, we use the number needed to harm, or NNH. This tells us exactly how many patients we have to treat to cause one additional adverse event, specifically due to that drug.
Just like our efficiency metric, this safety metric is a reciprocal. The NNH is 1 divided by the absolute risk increase, or ARI. It's the exact same logic we just used, but instead of looking at a reduction in bad disease outcomes, we're looking at the raw percentage point increase in adverse side effects compared to the placebo.
Let's trace this structural pathway with another practical example. So we're looking at a new pain medication, but we're auditing its safety profile specifically for new-onset hypertension. The standard care group had a hypertension rate of 1.6%. The new drug group, 2.4%. We subtract to find the absolute risk increase. 2.4% minus 1.6% gives an ARI of 0.8%. Divide 1 by 0.008, and we get exactly 125. Now, here is the mathematical law for safety. Unlike NNT, with NNH, you always round down to the nearest whole number to stay conservative. So if we got 125.9, we'd still round down to 125. Basically, for every 125 patients treated, you cause 1 extra case of hypertension. So the core clinical logic here is essentially a giant balancing act. You want your efficiency metric, the NNT, to be as low as humanly possible, meaning you treat very few people to see a benefit. And you want your safety metric, the NNH, to be as high as possible, meaning you have to treat a massive crowd of people before you cause even a single harm. Section 4, the live execution drill, synthesizing the clinical audit. Okay, let's dive into a live drill. Here we have the raw data for a new preventative therapeutic called Drug X. We're evaluating its ability to prevent colon cancer, but we also need to audit its tendency to cause a pretty severe adverse event, diarrhea. We've got a clear inverse relationship going on here. The placebo group has a 20% colon cancer rate and a 40% diarrhea rate. Drug X drops that cancer rate down to 15%, but whoops, it spikes the diarrhea rate up to 50%.
All right, step 1, let's calculate the efficiency. We take the 20% control event rate for the cancer, subtract the 15% experimental event rate. That gives us an absolute risk reduction of 5%. We divide 1 by 0.05, and that gives us a number needed to treat of 20.
Moving to step 2, let's audit the safety. The experimental adverse rate for diarrhea is 50% minus the 40% control rate. That leaves us with an absolute risk increase of 10%. Divide 1 by 0.10, and that results in a number needed to harm of 10. Which brings us to the clinical synthesis. For every 20 patients you treat, you prevent exactly 1 case of colon cancer. But because the NNH is 10, treating those exact same 20 patients will cause 2 of them to develop severe diarrhea. This synthesis forces you to actually weigh the risk-benefit profile in the real world. Is preventing 1 severe, life-threatening disease worth causing 2 cases of highly uncomfortable but milder side effects? Generally speaking, yes, this is a favorable profile, but you absolutely need that absolute context to make an informed clinical choice. As we wrap up this explainer, I really want to leave you with an executional pearl. We've got to address the most frequent gap people fall into when evaluating these impact measures, the hidden timeline. Think about it. Which is better, an NNT of 10 measured over a 5-year study or an NNT of 10 measured over a 1-year study? The answer is definitely the 1-year study. Because NNT and NNH do not exist in a temporal vacuum. They are entirely time-dependent. An NNT of 10 over 1 year means you get that life-saving benefit incredibly fast. An NNT of 10 over 5 years means you have to sustain that treatment with all its costs and creeping side effects for half a decade just to see the exact same benefit. Always check the study duration before you start comparing the NNT of 2 different interventions. At the end of the day, the true power of evidence-based medicine isn't found in the loudest marketing percentage pitched by the lawyer. It's found in the quiet, absolute numbers demanded by the judge. the numbers that represent real human lives, real clinical effort, and true patient outcomes. So the next time somebody pitches you a flashy 50% relative risk reduction, will you remember to audit the absolute signal? Thanks so much for walking through this explainer with me today. Catch you next time.